as we go through, if there is a point you want to bring up, a question, just let me know, as opposed to waiting till the end. So I'm going to show you sort of a multi-center study, some background about the term LV filling pressure. When we talk about LV filling pressure, some of you may be familiar with that, but the thing was prepared for people who may not necessarily be familiar with these terms. So basically, when we talk about LV filling pressures, we are talking about LV diastolic pressures. I don't know if I have a pointer here. No pointer.
Yes.
There is? Okay.
Just top left hand is your pointer.
Okay, thank you. So if you look at the phase of diastole, LV pressure drops fast during the isovolumic relaxation period. It reaches something called the LV minimal pressure. Then the mitral valve opens. At that point, we have what we call a crossover pressure point. Crossover meaning the two pressures are now equal. You have a positive gradient where the LA pressure, shown in blue, is higher than the LV pressure, shown in purple. And then as you fill the ventricle with blood, its pressure starts rising. The last pressure we have before the atrial contraction is called the pre-A pressure. It's that horizontal line. And then the atrium contracts, sends some blood into the ventricle, and we end up with the end diastolic pressure. The pressure that is very close to the left atrial pressure, the mean left atrial pressure, is that pre-A pressure. So if you're doing a left heart cath, you do not need a high fidelity pressure catheter to get these signals. And certainly if you're doing a PA catheter, you are not using high fidelity pressure signals, and we use wedge pressure. The wedge pressure is very close to the LAP, but if you want to be more meticulous, there are differences between them, particularly in patients with mitral valve disease. So long story short, what to take home from this message is when you read the term LV filling pressure, you want to be specific what pressure they are talking about. Is it the EDP? Is it the pre-A pressure? Or is it the mean LAP? Most of the time what you will see in the literature, what is the most practical thing to do are LV diastolic pressures on left heart cath. And for right heart cath with a PA catheter, you're going to look at wedge pressure. So the first question is, why bother and estimate LV filling pressure? So one reason is to know if the symptoms of dyspnea that a patient has are cardiac or non-cardiac in origin. Many times patients can say they have shortness of breath, and when you critically look at what is going on, you cannot come up to a diagnosis. Further, some individuals will have several conditions coexisting with one another. For example, obstructive airway disease plus heart failure with depressed or with preserved EF, chronic kidney disease, diabetics, anemics, etc. What is the cardiac component to that? It is a simplification to assume that even in cardiac patients, the dyspnea is just because of an elevated LV filling pressures. There are other variables involving pulmonary receptors, involving skeletal muscles that also contribute to the sensation of dyspnea. Next comes a couple of points I want to make. Many clinicians, perhaps not necessarily cardiologists, but more like internists, once they know that the ejection fraction is depressed, that's all they want to get from the echocardiogram. You have all seen patients, maybe treated patients, who come in with a depressed ejection fraction, have problems, but they are not really in clinical with elevated LV filling pressures. The flip side of that is sometimes we see patients who have a normal ejection fraction who are in heart failure with that, a condition well recognized as HFpEF. So equating imaging or echocardiography with ejection fraction to diagnose the etiology of dyspnea is not a good tactic or strategy to take. Finally, when you look at filling pressures, they are a marker of disease severity, particularly if you assess them after the patient gets treatment. Do they improve? Do they stay the same? There are several studies. Some are epidemiologic, some are single center studies. This is how this whole field started. which have shown that the grades of diastolic dysfunction can predict outcome, particularly after treatment. And sometimes even natural history studies have been done where you take someone, say, with a grade 1 who becomes grade 2 or 3 for one reason or another, and you see that clinical events start going up. So what is the available echo Doppler methodology for estimation of LV filling pressures? For talking about echo Doppler, there are other imaging modalities. They do not come close to echocardiography for that objective. Virtually all of them can give you LV filling indices. So they can tell you 30% of the filling of the ventricle happens in early diastole, 40%, 50%. And these indices can be measured and can be measured reliably. First used with radionuclide angiography, has been used with cardiac MRI more recently. The problem with the filling indices is they are exactly what they are, filling indices. And filling depends not just on the pressure of the left atrium, but also in LV diastolic function. So someone can have impaired relaxation, but elevated LAP will have normal filling indices. Without that hemodynamic piece of information, if you're just presented with a normal filling rate in early diastole, you cannot draw reliable conclusions about diastolic function. So for echo, we have several indices that you see on this slide that we acquire routinely. But one point of sort of to emphasize is for correct interpretation, it is not simply I measure one velocity or another. We have to put things together from these signals along with the clinical data, the heart rate, the blood pressure, because these affect the different signals that you see. We also have to look at 2D findings, left ventricular ejection fraction depressed or not, the presence of LVH. LVH here I'm talking about is pathologic left ventricular hypertrophy, like someone with hypertension, with aortic stenosis, with hypertrophic cardiomyopathy. These hearts are hearts that have diastolic dysfunction. Likewise, if you have someone with a depressed ejection fraction, their diastolic function is already abnormal. Probably will not dwell a lot on that, but to say this is the normal filling, predominant filling in early diastole, normal early diastolic velocity. If LAP is still normal but relaxation is impaired, you get that in flow pattern where E is less than A. Prolonged decel time, prolonged isovolumic relaxation time, reduced annular velocity. When compensation happens to keep the stroke volume going, because you want to keep LV filling going, particularly at a fast heart rate. You have, again, predominant filling in early diastole, short isovolumic relaxation time, short decel time, but the annular velocities are still reduced. Notice that it's not only annular E prime, but also annular A prime is reduced. The main advantage of these signals over the mitral inflow is you can see that the mitral inflow is tracking changes in LAP. This one doesn't track much the change in LAP. It's reduced here and it is still reduced here. So some technical points, not necessarily for the general audience, but more for cardiology fellows. You need, when we look at any signals, we have to scrutinize their quality. It is not just I look at the signal and I accept it. For example, look at the location here. We say we acquire annular velocities at the annulus, septal side, lateral side. See where the signal is, it's way down into the septum. Look at the quality of the gains here, look at the filters here. None of these three signals is a good signal. So when you're looking at studies, do not just measure something. Look at it, is it of decent quality or not? The same applies to the lateral velocities. You can see the sample volume placed partly in the wall, partly outside the wall, sometimes way outside, sometimes in the atrium. And you will still get early and late diastolic velocities, but obviously not suitable for analysis. Also, when you analyze these signals, you need to identify early diastolic velocity from isovolumic relaxation time velocity. These are biphasic signals during the isovolumic relaxation time and during the isovolumic contraction time. Not uncommon in patients with conduction diseases. Okay. So now we sort of say, what are the findings that can tell us there is diastolic dysfunction in someone with a normal EF where I do not see left ventricular hypertrophy, I do not see left atrial enlargement? Are there some other things that we can do to diagnose that? And these are some signals that can be done or acquired and obviously analyzed. So the first one is looking at mitral inflow and looking at pulmonary venous flow. Pulmonary venous flow has forward flow systole, diastole, and then with atrial contraction, when the atrium contracts, it sends some blood across the mitral valve into the ventricle to fill the ventricle, and some blood goes back into the pulmonary vein, and you end up with this signal. How big is that atrial reversal compared to mitral inflow? Could be an indicator of late diastolic pressures. If you see a very big AR, then LV and diastolic pressure is elevated. Also, if you see more filling in diastole of the atrium as opposed to systole, this goes with an elevated left atrial pressure. More reliable when LV ejection fraction is depressed. We can do a Valsalva, not we, the patient can do a Valsalva maneuver. And if they have a drop in their left atrial pressure, which should happen during the strain phase, you will see a change in the mitral inflow pattern. So that tells us that the left atrial pressure was up here and it dropped when they did that approach of decreasing venous return and lowering left atrial pressure. The problem with the Valsalva, it takes time to do. It's difficult to standardize. Some patients will not cooperate. So in special situations, it may be done in our lab, but there are labs that have it routinely. Overall, pretty specific if you see it, but sensitivity is not that great. Another signal that you can look for is what the arrow points to in mid-diastole. If you remember, there is forward flow in early diastole and in late diastole from the very early slide. Then you saw the crossover points where the LA and LV pressures are overlapping one another. But in someone with impaired relaxation and still elevated LAP, you will have a positive gradient in mid-diastole and will result in that signal called the L wave or L velocity. Normal would be no more than 20 centimeters per second. If it is 50 or above, it's usually abnormal, and you can record it also in the annular velocities. So say I end up with a study where I do not see the mitral inflow L wave velocity, I do not have a Valsalva maneuver, the pulmonary vein signal is not that good. What am I going to do? We can look at evidence of myocardial disease. And one evidence of myocardial disease is longitudinal strain. This measures the compression of the ventricle during systole. You see an example here from a patient with heart failure reduced EF, heart failure preserved EF, and a normal subject. If you look at the longitudinal strain, which is this one, this is circumferential and this is radial, the longitudinal strain is profoundly reduced in the patient with heart failure preserved EF, previously termed diastolic heart failure, whereas everything is reduced in heart failure reduced EF. This patient is not a challenge to recognize because I see their ejection fraction, I see their ventricular volumes. This is the group that is more challenging to recognize, particularly if you do not see structural abnormalities in terms of LA enlargement or in terms of left ventricular hypertrophy. So this takes us to recently developed guidelines, updated guidelines for diagnosis of diastolic dysfunction and estimation of filling pressures. This was a joint effort between ASE and European Association of Cardiovascular Imaging. There was a big writing group, and we thought of approaches to diagnose diastolic dysfunction in the absence of the parameters that I just showed you. That does not mean that these parameters should not be used. They should be used. But say I end up with a study where I do not have anything else, then I have to rely on some other findings and see where these findings tilt. The thought was we want to be more specific than sensitive, so you do not want to label too many patients with diastolic dysfunction and cardiac disease. And if you have that objective, then you say, I want more variables to be abnormal before I call someone having diastolic dysfunction. And also I try to select values that detect higher filling pressures with greater specificity. So of these variables, one of them is average E to E prime. The cutoff was more than 14. I'll comment on the annular velocities in a moment. A peak TR velocity more than 2.8 meters per second, and an LA maximum volume index of 34 mLs per square meter. This was sort of a consensus decision of keeping these values, but the document actually says if you know normal values for older age groups, so we are not talking about someone who's 30, 40, 50, we're talking someone who's, say, 70. 70 years of age, having an annular velocity of 7 or 10 may be okay, but younger age groups, these values are reasonable. The numbers came up from a group of normal studies that were published. Some of them were epidemiologic, some of them were more recently published, not as old. One of them is the NOR study, where if you look at the percent of normal subjects, say with an abnormal E to E prime ratio more than 14, was less than 1%. So that puts you into a comfortable zone when you use this parameter. And then you say, I have 4 variables. If the majority of the variables, so in this case, 4 of 4, 3 of 4, or if I only have 3 variables, 2 of 3 or 3 of 3 are abnormal, then there is diastolic dysfunction. If I don't have any or 1, then we are not going to diagnose diastolic dysfunction. In between, we will call it indeterminate. That doesn't mean they do not have diastolic dysfunction. It's just we do not feel comfortable labeling it as such.
Yeah, when was this published?
April 2016, Journal of the American Society of Echo.
It seems like a lot of weight was put on the LV volume index.
LA,
Yeah, the volume index based on the BSA, body surface area.
yes.
But as individuals put on weight and their body surface area goes up 1.6 to say 2.4, and the left atrial volume goes from 35 or 36 up to 55, when you correct it, it comes down under 34. Yet they're describing dyspnea, shortness of breath with exertion, climbing stairs, getting short of breath.
Yep.
Is that accurate when you correct it? I mean, how do you know that?
So
I see now
two
having
comments.
The other 3 parameters
Yeah.
there.
So one of the responses is LA volume index is not sort of the only variable. It's one of the other variables. But there are actually studies that looked at indexing LA volume for body height raised to powers, different powers. One of them is, say, 2.7, and one of them just to body surface area. It was published in one of the cardiology journals, American Journal of Cardiology, from the Heart and Soul study, and prediction of outcome was not any different when you use the body surface area to index the LA volume as opposed to using other ways of indexing body surface, of indexing LA volume to body size. So that,
Indexing is always difficult. Because that index can be all over the place, particularly with obesity. And I mean, we use it less. But in extremes, it becomes trouble bad. That's the way I see it. And if indeed the heart size is bigger because the body size is big, really everything should get big. Meaning the ventricle, the right ventricle, the left ventricle, the left atrium, the right atrium, all of them should be big. So one index for our eye to say, well, left atrium is much bigger than the others. And therefore there's some conceivable pathology because your rationale for indexing is that the demands are higher, or the size is higher
It's
because of
getting
the body.
bigger because the body's bigger.
yeah, and by the way,
Not because there's
yeah.
some cardiac dysfunction, which there is your BMI.
If somebody is acromegaly, because somebody has the same body surface area than somebody who is obese
Yeah,
with the
then-
same surface area, cardiac output is different between them because fat doesn't require as much blood as body mass.
But many also of these individuals with large body surface area and obesity have large ventricles, as Bill is mentioning. So whether it is what extent is pathologic or not, in fact, in our own sort of community, there are strong voices saying the upper limits of normal shouldn't even be 34, should be higher. And some of that came from normal data that included select groups that did not discriminate based on complete absence of disease or whether an individual is an athlete or not. So in athletes, if we do BSA after indexing LA volume, you end up with pretty large values. We may see 40, 45, even 50, and that is not abnormal.
Yeah, I like the idea of having 3 or 4 parameters.
Yeah.
But does the E prime read out? I hear we see it a lot, but a lot of echoes if we get in, from other patients from other institutions we see, we may not see that on there. You know,
Meaning the acquisition?
Yeah, so they might have a left atrial volume of 57, you know, and you normalize it's 34, 33, but the other parameters I'd always say are that E prime velocity, the septal E prime velocity, E to E prime ratio. It's not often there on the reports.
So 2 things. Sometimes physicians have acquired it and they are using it to draw their conclusion without disclosing the value in the report. Sometimes it's in the report and they have used it, and sometimes they haven't even acquired it. But it is a standard of care. It is in the accreditation standards that labs, yes, that labs should acquire it and use it. Of those variables, the one actually with the least feasibility is the TR, peak tricuspid regurgitation velocity. It requires the sonographer to look for it in multiple views to enhance the signals if needed, and sometimes, particularly in individuals with normal PA pressures, you may not end up with such a signal. So that's an example of someone who has normal velocities. Peak TR was 2.4. By the way, a critical point to make. Compared to previous guidelines, these are explicit in saying if I only have one abnormal value, the person would be called normal diastolic function. So for example, someone with a septal E velocity of 6, an E to E prime of 10 average, a peak TR of 2.4, LA volume index of 30, just because the annular velocity septal E is reduced, that doesn't put them into diastolic dysfunction group. And I'll tell you later on something recently published that validates this approach. Okay, so now if we've decided that the person has diastolic dysfunction, we go on to this algorithm. So this is a second step, not a first step. And we look at their mitral inflow at first. This is the so-called impaired relaxation pattern with reduced mitral E velocity. This is what we call a restrictive pattern, and then we end up with a mix in the middle where we need other data because patients with these findings on the mitral inflow may have normal or may have elevated filling pressures. And here we introduce again the average E to E prime ratio, the LA volume index, the peak TR velocity, and also pulmonary veins if they were acquired and we do not have one of these signals either absent altogether or not of a satisfactory quality. So if we end up with a ratio of 2, we are done. We call it elevated LAP, and this is grade 3 diastolic dysfunction. If we are here, it's normal LAP and grade 1 diastolic dysfunction. In between, we look for the majority of these values. Where do they fall? 3 of 3 abnormal, 2 of 3 abnormal, then LAP is up. Only 1 positive or 1 negative, that's indeterminate. When only 2 criteria are available, both of them going in the same direction, that's normal LAP. One thing also noted in this guideline that is explicit, say we see someone who has symptoms of shortness of breath, and the report comes with a normal left atrial pressure at baseline, which is at rest when it is acquired. Does that rule a cardiac etiology altogether? It should not if particularly the physician has looked at other alternatives, for example, pulmonary disease. So the recommendations are to consider stress testing to look for CAD, or also consider the diastolic stress test. But these are the guidelines. When they were conceived, there were no data looking at their accuracy. There was no data looking at, do we need them compared to clinical assessment even alone? Many physicians are comfortable examining patients and saying, I looked at their neck veins, third heart sound, chest x-ray, BMP, whatever it is, and I'm comfortable they have heart failure. Why do I need an echocardiogram still? So we thought of this.
It's very interesting. Go back to what you said. Remember, you had, in the past, you had 4 criteria, right? I mean, in that previous,
Yes.
right? Now, if I don't have all 4, I don't have to necessarily decrease my number of criteria to still keep it either positive or negative.
Don't understand.
If I have 3 out of the 4,
And so you have 3, and 3 out of the 3 or 2 out of the 3 are abnormal, that's enough to make a call.
I understand. But since each one has issues, right? The 2 positive, even if I have 3, 2 positive is somewhat indeterminate.
2 out of the 3? This is not the guidelines statement. I see your point. This one, okay, this one is saying I have 2 out of 4 positive, not 2 out of 3.
The problem is we're putting equal weight. I mean, I know that because the other guidelines have the same issues. You're putting equal weight. When you say that, you have equal weight.
Absolutely. So we had this discussion.
I know you're going to have discussion about that.
No, we had that at the time it was written within our group before even reviews. Do I put the same weight for an E to E prime of 14, more than 14, as I put, say, on a septal less than 7? Particularly that E to E prime more than 14 is present in less than 1% of normals, whereas this one may be detected in up to 20% of normals. The consensus, and it's a big group, you try to build consensus, was it is better to sort of have them stand the way they are. And the solution was we are sort of introducing other variables to take care of that. So there may be some loss of sensitivity.
That's not, the way I see that slide, that is not criteria for diastolic dysfunction. That's criteria for elevated feeding pressures.
So you are,
Your E prime, you have high TR velocity, peak LA, all of those things point towards high feeding pressure rather than that.
so
You may have diastolic dysfunction with normal feeding pressures. So
Correct.
it has become more specific. So I understand the specificity.
Yeah.
But you have lost a lot of sensitivity of picking up people
Okay.
that have diastolic
okay,
dysfunction,
so
but
2
don't
points.
yet have high feeding pressures at rest, because these are at rest.
Okay, these should be applied in patients where you're looking at their clinical data, you're looking at their echocardiogram, and you do not have any history of clinical disease. You are not seeing LVH. There is nothing there, or coronary disease. In that setting, then we go to these criteria. But if you see a heart with LVH, that's enough to call diastolic dysfunction. If you see a heart where you have nice pulmonary veins and you have an atrial reversal, that enough is to call diastolic dysfunction, and so on. So this is in the group of patients where there is nothing is present to go around to make a call.
I understand that, but people take these things, put them in the wall in the echo lab,
I
and they
know.
become the gospel.
Yeah. Don't disagree, but there is no substitute for reading the actual text.
Don't we have them in our lab too? They're already on the wall.
Yeah, the issue is not, people have to know what is written and be comfortable with it. But that again is the first step. One should not estimate filling pressures if you have determined that the patient does not have diastolic dysfunction, or you cannot call diastolic dysfunction. Otherwise, these estimates may not be accurate. And I'll show you their performance in a setting of this multicenter study.
But I'm sorry to belabor the point.
Okay.
But what I'm saying is, go back to this slide to the second one.
Second one, which one?
See, when you have 2 positive of these, right, it becomes indeterminate.
2 out of 4,
2 out of
assuming that I have all 4.
We understand. I have 2 out of 4. I'm an internal. Go next. Go next. If I have 2 positive, I become, because my availability is less, it becomes high left atrial pressure with grade 2 dialysis. See, the
No.
criteria have not changed. It's just not present.
No,
You
this
understand my
is
point?
somewhat, so this could be somebody with a depressed ejection fraction, okay? So someone with a depressed EF has diastolic dysfunction. I do not need any of the 4 criteria,
Or normal EF.
okay? But normal EF with diastolic dysfunction. So if I am normal EF and there is diastolic dysfunction, how did I determine the presence of
Yes, I
diastolic
have only
dysfunction?
3.
No. Could be with the pulmonary veins, could be the presence of LVH, could be the L wave velocity.
So this is a
And
diagnosis of
strain.
diastolic dysfunction. This is
Filling
filling
pressures now
after diastolic
has been established. If you have not established it, then this doesn't come in. So our objectives were, 1, identify the feasibility and accuracy of this methodology, basically look at how feasible it is to apply these guidelines and how do they perform against the gold standard of cath. Second, look at the question of clinical assessment and does echo add anything to that, and what do you do if you combine them together. It's a multi-center study from these sites. And we looked at several standard measurements: LV volumes, ejection fraction, LA maximum volume index, mitral velocities, annulus velocities, pulmonary veins, peak TR velocity, and PA systolic pressure using the non-invasive estimation of RAP. We looked at visual assessment of RV function, MR, and tricuspid regurg severity. And of course, we noted the rhythm and other things, clinical, for example, the presence of diabetes, hypertension, medications, and so on. Measurements obtained at cath, where as you see them, these are pretty standard. We had a group of 157 patients who had either left heart cath only or left heart plus right heart cath, and so in that group, we had end diastolic pressure and pre-A pressure. So this is a group of 451 patients. Their mean age was 59. The majority were males. Diabetes was present in 10%, chronic kidney disease 10%, hypertensives in 31%, CAD 26%. Their left ventricular end diastolic volume on average was 154, but notice the large standard deviation. And ejection fraction, left atrial maximum volume index was 45, so many patients were with enlarged left atria. Mean ejection fraction of the group was 47%, again, large standard deviation reflecting the inclusion of patients with depressed EF. The E to A ratio on average was 1.6, and the E to E prime ratio on average was 13.9 with a big standard deviation. All patients were in sinus rhythm except for 18 in atrial fibrillation, 41 patients in left bundle branch block and ventricular pacing. I'm emphasizing these because these are more challenging situations to estimate filling pressures in. RV function was normal in 68%, moderately severe or severe MR in 19 patients, but as you can tell, this is not a study about filling pressures in patients with mitral regurg. AS, as they came, of at least moderate severity in 8. Pulmonary disease was quite common, or relatively common, shouldn't say quite common, in 71 cases, which reflects the fact that many times patients with pulmonary disease go for right heart cath, or patients with either to know why they are short of breath or to sort of assess their hemodynamics in response to something, some of their treatments.
For this, what were the exclusion criteria?
The only 2 exclusion criteria were cardiac transplants and patients with complex congenital heart disease.
Okay.
So an ASD could come in, a VSD could come in, but we didn't have any cases like
Because
these.
the problem is when you start throwing in left bundle branch block, I know they're not allowed, but they are 41. When you start throwing in curves that you know in this population doesn't work well, neither you can generalize to the total population, nor you can identify it in individuals so, and same thing as, I don't have to tell you that because you published on it, mildly severe and severe MR. You know, I mean, and it's not like the population of mild and severe MR, is you got 19 here, and 41 there, and 8 there, and 10 there.
So AS
right?
by itself shouldn't be an issue. The ones that are challenging,
Pulmonary disease is going to be a big issue.
so let us look at how it performed there.
I understand, but how do you diagnose pulmonary disease? How is that diagnosed?
So that was diagnosed based on review of their medical records and PFTs and cardiac catheterization to identify those with type 1 pulmonary hypertension. So that was available. Now, why were they included? The investigators felt that not excluding anyone for these reasons would be good. We can do the analysis with and without these cases since they are small, and that will be presented. So now the hemodynamics summary. The heart rate was 75. The cardiac index on average was 2.3. Blood pressure decent for most cases. PA pressure is 47/20. The wedge was about 17. The EDP in those that had an EDP was 21, and the mean RAP was 10.
Sherif, I'm sorry, you may have said that, but what was the time difference between non-invasive and invasive?
So in all cases, they were either simultaneous or a difference of at most 3 hours between the two. Distribution of wedge pressure in patients with normally depressed EF. So we had 209 patients where EF was less than 50%, and 241 patients where EF was 50% or above. 58% had elevated filling pressures. Notice that 60% of the patients with depressed EF had elevated filling pressures. Conversely, 40% did not. And in patients with EF of at least 50%, roughly close to 60% of them also had elevated filling pressures. So EF from there, you can tell would not, if you were waiting for EF to tell you what the pressures are, you would be mischaracterizing 40% in one group and close to 40+% in another group. Feasibility. So after review of these charts, it was felt that clinically you can say that filling pressures were normal or elevated in the vast majority of cases, just 2 patients. There wasn't enough to go by. Echo Doppler methodology was feasible in 93%. So that includes the cases where you look at everything that you have and you go to that very first algorithm with the 4 variables, and you end up saying we are sort of inconclusive.
I'm sorry, Sherif, the first one? Clinical assessment feasible, what do you mean by clinical assessment?
So for example, we looked at the chart. Okay, we looked at the physical exam findings, the chest x-ray, the symptoms, BMP. Then the data, does it support the diagnosis of someone being in heart failure with elevated filling pressures or not?
Wow, 99.6%?
So two cases were felt not enough info. Again, remember, these are cardiologists looking at these charts.
Don't show that to an insurance company, they're going to say that you don't need an echo at all.
So that's a good question. You will see how that performed, okay? I mean, I could assess it, but I am wrong.
But the first,
Oh, feasible, meaning that they felt they could do it, not necessarily
Yeah.
that they were accurate.
Yes.
Got it.
but what's,
Okay.
I'm sorry, but this is an assessment of whether they do have heart failure, yes, no, clinically, based on symptoms.
Symptoms, physical exam findings as documented in the chart, chest x-ray and BMP if it were obtained.
And based on a consensus, I mean, there are consensus documents of how do you do that.
Yes.
And I know it's not very accurate, but,
Yes.
right?
Yes.
Okay. And so this is at each site, I presume.
Yes. Each investigator.
So this is feasibility regardless of accuracy.
Yes.
Okay.
So all of that is feasibility regardless of accuracy.
Got it.
Okay.
Okay. So the Doppler methodology now, it was feasible in the vast majority of cases, 93%, but in about 31 cases it was not feasible. Again, we are looking at signals, the quality of the signals, and things of that nature. So that dropped several
Was
cases.
this done through a core lab?
Each side did their own analysis.
Okay, good.
Then there were 31 other cases where you apply the algorithm, the very first algorithm, and you end up with one criterion abnormal or two criteria going opposite each other, and then you end up being inconclusive. Okay? This is the algorithm. Again, I'm just showing it up because I will show you the numbers of the different boxes that you see here. Remember, we start with the mitral velocities, and then where we end up in this middle group, we want to look at the criteria that are abnormal and how many you see in them. So we had 235 cases with elevated filling pressures and 184 with normal. If you look at the first one, mitral E to A ratio 0.8 or less, along with mitral E velocity 50 centimeters per second or less, 26 of those with normal filling pressures had that finding, and so the assessment ends here per the guidelines. You do not need to look at other variables. None of the patients with elevated filling pressures had this finding. So in other words, if you're looking at an echocardiogram in someone with diastolic dysfunction, and you have an E to A ratio less than 0.8, and a mitral E, say, of 40 centimeters per second, the odds are very high their LAP is normal. How about mitral E to A ratio 2 or above? So that's the restrictive filling. Of those with elevated filling pressures, 72 were correctly classified just based on the mitral inflow. And again, if you remember the guidelines, this is where sort of the assessment arrives at a conclusion, stopping point. However, 9 of the 184 cases also had that finding.
9 of the normal.
9 of the normal filling pressures. Some comments about these. Some of these cases where pressures, the definition of an elevated wedge pressure was what was used in the diastolic heart failure guidelines, which is 12 millimeters of mercury. So if you have someone with 13, they will fall in, in the elevated filling pressure group.
What were those 9? Were they like on the lower end?
So some of them were borderline values, like 2, 2.1. Some of them were cases that had a bundle branch block, which is a challenge. But these were these 9 cases. So now we go to the group where we say how many abnormal, you remember the 3 variables we talked about? If you have an LA volume that is enlarged, an E to E prime that is more than 14, a peak TR that is at least more than 2.8, 43 of those with elevated filling pressures had that finding. This person, only 1 patient in those with normal filling pressure had 3 abnormal findings. This person had a wedge pressure of 12, and that's the situation. How about 2 abnormal findings? You can see that more cases with elevated filling pressures had 2 abnormal findings than cases with normal filling pressures had 2 or more abnormal findings. Usually the LA volume and the mitral E to E prime tracked one another as opposed to LA volume and TR or mitral E to E prime and TR. This shows the frequency of 1 abnormal finding only, and as you expect, those with normal filling pressures, this was more frequently the case than in those with elevated filling pressures.
Go back. I mean, this problem, the 2 abnormal is problematic.
2 or more abnormal.
Yeah, quite problematic. Because it's neither sensitive nor specific.
Okay, so one comment about this. This includes...
I'm sorry, but I have 235 patients, of which I've excluded the 72, right, and the 43. So I still end up with 100-some patients, right? And I'm picking up, with 2 abnormals, I'm picking up about 60.
Okay. Just a comment here that is sort of perhaps not clear from the slide. this includes also the cases that are inconclusive by the algorithm. See, the algorithm stops if I say inconclusive, if I say that LAP estimation is inconclusive, that's an endpoint by itself. Here we are showing the variables even in those where we said it's inconclusive. Remember, if I have 4 variables, or I have 3 variables, and 2 of them are abnormal, or 2 out of 4 are abnormal, it will...
Data, it's validating that it's better to say, I cannot say. The next slide, what you're doing with that
Is-
slide is
is-
validating the
yes.
fact that when it's inconclusive, it's better to say it's inconclusive.
Yes.
Because you could err on both sides.
So this is including everybody, even in those where the algorithm said it's inconclusive.
Yeah, so you're demonstrating that in fact it is inconclusive.
Yes, it-
Because you have errors on both sides.
Yeah.
Yeah, okay.
Okay. Now, a particularly interesting group of patients are those with EF less than 35%. Why interesting group of patients? Because some studies have been published questioning the use of Doppler methodology in general in this group of individuals. So in this series of patients, we had 159 patients. LV filling pressure was elevated in the vast majority, 135, normal in 24 cases. When you apply the algorithm, you end up with 11 where it is indeterminate. And then if you subtract these 11, you have 129 cases with elevated filling pressures and 19 with normal. The algorithm correctly identified the vast majority of those with elevated filling pressures and only missed 1 case with normal filling pressure. So it works well in this group of patients with depressed EF. These are sort of the specific patient groups, not that I am advocating use the approach for them. By the way, if you look at the guidelines, each of these situations has a separate section. So the algorithm to apply or the approach to apply in patients with AFib, in someone with MR, in someone with left bundle branch block is not the general guidelines you saw. They have their own specific indications. Not much to make of their accuracy because of the small numbers, but this is how it performed.
It looked pretty good.
Could be a chance finding because we have few cases. The interesting thing I would say about MR, most of us, when we think we have a patient with mitral regurg going for cath, their LAP is up or their wedge pressure is up. Not the case. We've had patients with normal PA pressures, severe mitral regurg, normal pre-A, normal EDP, normal wedge pressure. So MR in people who are compensated is indeed associated with normal pressures or can be associated with normal pressures. Now the accuracy of the clinical and the echocardiogram against the invasive pressure measurements. So this clinical approach was accurate 74%. The accuracy for echo. Remember this.
Just to clarify, now you're talking about diagnostic accuracy, which is when you combine both sensitivity and specificity.
Yes.
Okay, just for clarification.
Yes.
Okay.
Yes.
You all understand how you calculate that, fellows? You understand how you do that? What's the formula that you use for that?
You should all know that, right?
This is bread and butter.
Divided by 1.
So you get all those that are accurate in terms of those correctly identified with normal pressures, those
So
correctly
true
identified
positive
elevated
plus true negative
overall.
divided by everybody. Okay.
I didn't do any of that analysis. I
If you
don't
have
take credit for
100
it.
patients, if you had 70, you have 52 positive and 42 true negative, that would be 92 divided by 100. So it's how well you did on both sides.
Okay.
Okay.
So we have the overall accuracy at the bottom here, but this is sensitivity, specificity. These are the sort of the standards.
Right.
And they give you the 95% confidence intervals. So clinical was 74%, echo is 87. Remember this 87 after excluding the 31 where it was not feasible, and the group where echo said we cannot determine what LAP is. And that was significant. Echo was also more specific.
So you took away the indeterminate.
The indeterminate.
Okay.
Is that fair?
So,
The
no, no.
clinician did not say that. The clinician did not have an undeterminate.
So I agree with you.
Yeah. But I mean, to be fair, if you're gonna have to put this, you're gonna have to tell us what's the indeterminate rate.
Was 6.3% or 6.9%. Yes, I had it on an earlier slide. 6.9%.
Okay.
Doppler, inconclusive due, oh, it's inconclusive due to inability to acquire.
So meaning missing signals.
No, but that's not the same as the algorithm. When you later on show us a slide. with
Okay,
the
yes,
algorithm,
but what I'm saying here is I need 3 say signals, right, to make the algorithm work.
Right.
I only have 2.
Okay, so this is inclusive of that.
Yes,
So 7%.
7%.
So, hold on, go to the previous slide.
Yes.
Next slide. Just to clarify, so that light blue region, that was 6.9%. That's correct?
And yes,
Am I
and that
correct?
resulted in,
Yeah. So
because
only in 7% of the entire population, you ended up in that blue range, and you say cannot determine.
because we want to have at least 3 criteria,
Okay, that's
but
fine.
it happened that we had
That's good.
1 or 2.
Yeah, no, that's fine. That's pretty good, actually. In real life.
So
that's
explaining
fine.
why it was.
And that group was taken out when you calculated these.
Yes.
analysis. Okay.
Clinical is physical exam.
Including what?
When you say clinical, it's physical exam and some.
X-ray.
So X-ray, physical, the complete chart review.
What you use as a doctor, putting them together. Yeah, well, yeah.
By the way, this has been done before in some of the early studies, for example, validating BMP measurements and comparing it with clinical data. That was done before.
No BNP.
No, if it were obtained, it was looked at, yes. And we have it in roughly like 100-some patients,
It helps the sensitivity, but it drops the specificity.
particularly with depressed EF.
Sure.
So these are the values. If you just go to the accuracy, clinically the accuracy was 72%, the echo accuracy was 87%. Now let us look at subgroups. So there is the group with depressed EF.
You know what I would have liked, I hope, I don't know if, go back a little bit,
Sorry.
go back, back, okay. I do hope either when you publish it, if it is not published, I haven't seen it, or whatever it is, that you put the accuracy of each one of these here.
Yeah. That you enter them. That would be a nice figure.
Do you mean these numbers there? Put these numbers there? Like similar to these numbers and put
The
them?
accuracy, I mean, meaning how accurate I am if I'm gonna go through this table and go down here,
Mhm.
what's my accuracy? Is it 80%, 90%, 100?
So
My accuracy here. Obviously
Okay.
here, you don't need accuracy because you're saying
I cannot do it.
you can't do it. But what's my accuracy here, my accuracy here? Because if I'm gonna use this algorithm, I wanna
we
I
have
wanna
an
know where I
analysis which also looks at the wedge pressure across the different grades. Grade 1, grade 2, grade 3,
am. Forget it. I
which
mean,
is not the
let me
same
tell you.
though as that.
This is gonna be on
Okay.
on the wall of everywhere, or on an app, or something like this, right?
Yeah.
So you want to know, you know, if it is not accuracy, how sensitive or how specific it is.
No, it's a good idea. I agree.
Okay. The
Is this
tricky
out yet
part,
already or not?
it's undergoing revisions if I get around to do the revisions
You get it right.
in an infamous journal. If I get to do the
Sherif,
revisions.
How did you maintain blindness?
So in different sites had their own, they had 2 different teams, people that acquired the cath data and those that acquired the echo data.
And hopefully there were no leaks.
I mean,
No, the other thing is, I mean, you have to be transparent here, right? Is The guidelines were out in April, and you have 450 some patients. How many of those were done before the guidelines?
Okay. So it is transparent in the manuscript.
Exactly. Gotta
Yeah.
be.
Yeah, it is transparent. We have 180 patients from before that were included.
I'm reusing patients that I've done before, one way or another. This time a prospective trial.
180 cases were used in previous studies,
How many?
180, but the rest were all prospective.
That many?
Yes. The rest were all prospective.
Wow.
We started the work on
I
this
say wow because
from January.
As you know, we've looked, with 2 fellows. It took forever.
Now, 2 fellows for MAC. This is not MAC.
Mac or no Mac, I mean, they
No,
were
actually, the heart failure group does a lot of caths here, a lot of PA catheters in the ICUs, so some of these were included here. In some other centers, like the Cleveland Clinic, they do more than 50 to 80 right heart caths a day. So the challenge was, how many can we catch in a given day? Believe it or not, the practice of cath for filling pressures is not necessarily declining among the heart failure community. Am I correct? It's actually increasing. Yeah. So if you look at the group with EF less than 50%, clinical accuracy was 81%, which is not bad, by the way, solid. 91% for echo. This is the group that is of, I think, more challenge for both techniques. Clinical accuracy only 64%, echo accuracy 84%. And there are some opinions that if you have somebody who has heart failure symptoms and a normal EF, you do not need echo, you do not need cath. They will have heart failure with preserved EF. So all you need is a clinical diagnosis of heart failure plus an echo that tells you EF is normal. You don't need anything else. And you can see that this failed in 36% of the cases. You can argue how good the clinical assessment was. It is as good as those who are doing it. But that's a situation which I think is probably even the better situation than the real world setting.
It's interesting because as I recall, one of the studies to define heart failure, right, was the response to therapy, to diuretic.
That's one of the criteria.
Exactly. So they respond to diuretic.
Then they have had heart
then they have
failure.
heart failure.
You would want to know before you use the diuretic with its problems,
Yeah, but
do they have it
That's
or
a
not?
medicine.
Okay.
It's practice, believe me.
Okay.
It's still there now, right?
Obesity performance, interestingly, even clinically, I mean, you would think obese people are hard to examine. They are short of breath. How easy it is to look at their neck veins, to hear a third heart sound, to interpret a chest X-ray. BMP values can be reduced in obese individuals, but still wasn't too bad. Echo still did better.
What was the BMI?
Was 1.95, the mean for the group, but we had some people with weights 300s plus.
Is that obesity without diabetes? So
Um,
the 2 groups don't overlap there?
There are
Oh,
some.
there's overlap.
There are some.
Only groups overlap, most of them overlap.
Diabetes, I don't know what to make of that. The numbers are small now as you go into diabetes and chronic kidney disease. Hypertension, important. Coronary artery disease, important. Pulmonary disease, clinical assessment, not good, which is probably not a surprise. But also an important group to correctly identify because there comes the issue of diuretics and what follows from them. Echo accuracy was not the best there, was 81%. This looks at the net reclassification improvement with echo and clinical assessment, and they were significant. I do not claim to understand how they are necessarily done, but these were sort of the standard analysis approaches for these. So other questions to answer from this database. One of the recommendations in the guidelines is saying you can identify patients with diastolic dysfunction based on the presence of abnormal global longitudinal strain. How frequently this is present, how feasible it is to do that against the gold standard of invasive cath is not known. So we have work in progress looking at that question. There is interest in diastolic strain rate of the ventricle, early, late diastole, mostly the early diastolic signal. Can that be used to identify patients with diastolic dysfunction in combination with mitral E to estimate filling pressures? We have work in progress also looking at that. Left atrial strain. Left atrium is a chamber where we are interested in predicting the pressure, so it makes the most sense to look at left atrial strain and relate that to filling pressures in this patient population, and there is also work in progress.
Some papers have been very encouraging.
Mostly single center studies,
Single centers, yeah.
and including patients with heart failure, depressed EF, really low ejection fractions as well. The signal in atrial strain that has been most promising is the systolic signal related to the reservoir function of the atrium. As atrial pressure goes up, that signal decreases. Other questions, the writing group went with the recommendation of using peak TR velocity as opposed to PA systolic pressure. And the European colleagues' point of view was because they have pulmonary hypertension guidelines, which de-emphasize PA systolic and emphasize more peak TR velocity, let's use that as well here. Their thought behind why you do not want to use PA systolic but you want to use more of the peak TR is you end up with RAP estimation, and RAP estimation is not as accurate. We should rely on a signal that is more solid, and that is the TR velocity. Their guidelines for pulmonary hypertension were never validated. Here we have, in a good number of cases, patients where we have both TR and we have estimates of RAP, so we can answer the question of whether PA systolic adds to the accuracy compared to peak TR velocity alone. Another question to add is the recommendations and inter-observer consistency. The older guidelines were looked at, and there was an expectation that whoever is going to apply them has to put things together. However, some people used them more of, it has to be, all variables have to be met before I call something normal or abnormal. And work was published from Tom Marwick in JACC Imaging a number of years ago showing that the inter-observer consistency is better for estimating filling pressures than for grading diastolic dysfunction. When you look at these guidelines, they are very specific. They are calling for how many variables, how many of these are abnormal, these are the exact values. So you would expect them to get better inter-observer consistency. And we would be able to address that not only among different observers, but also compare that with the filling pressures, because we know that whoever said is elevated or not elevated is accurate or inaccurate. And that's also work in progress with other sites. So that's briefly what I wanted to share with you.
Very nice, Sherif.
Thank you, guys.